Today I will be talking about Huntington's disease within the field of speech-language pathology. The purpose of this presentation is to investigate how speech-language pathologists work with people with Huntington's disease. Huntington's disease is an inherited and progressive neurodegenerative disease that causes disturbances in movement. Further background information is provided in this section. Several research articles were reviewed in order to build a strong foundation of how this disease affects the body and brain. Several research articles were reviewed in order to also discuss the speech, language, cognitive, and swallowing impairments. Huntington's disease is the deterioration of the brain that causes numerous impairments, many of which are pertinent to the field of speech-language pathology. According to the National Institute of Health, Huntington's disease is an inherited disorder that causes neurons to die in various areas of the brain, including those that control voluntary movement. Huntington's disease is inherited through an autosomal dominant pattern, meaning if a parent has Huntington's disease, their child has a 50-50 chance of also developing Huntington's disease. Adult onset of this disease begins between 30 and 50 years. There is juvenile Huntington's disease, which has an onset of younger than 20 years of age. This has some different symptoms, including rigidity, slowness, difficulty at school, and seizures. However, during this presentation, I will be focusing on adult onset of Huntington's disease. This disease is caused by a gene mutation which affects the protein Huntington. This disease is progressive, meaning that the symptoms get worse as more area of the brain deteriorates over time. There is no known cure or treatment at this time. The symptoms of Huntington's disease include uncontrolled movements or chorea, and this is why Huntington's disease is also called Huntington's chorea. Another symptom is abnormal posture, changes in cognition, dysarthria, and feeding and swallowing difficulties. And I'll be going into more details about these symptoms throughout the rest of this presentation. I will now talk a little bit about the history of Huntington's disease. It was first described in 1872 by George Huntington, who is pictured here on the right. Predictive testing became available in 1987, and they identified the gene mutation in 1993. A recent study found that only 5 to 10% of those at risk for Huntington's disease actually pursue this predictive testing. The study found that more females requested the test, and the average age of those requesting the test were between 31 and 40 years, which is around the age of onset for the disease. The study also found that most people requesting the test already had children. Many people reported that they still would have children even if they knew about the risk of passing it to their children. The researchers believe that many people have a great value in having children and is a significant part of their identity. Therefore, this disease will not stop them. In the next slide, I will talk more about the gene mutation that gets inherited throughout families. Huntington's disease is caused by the toxic presence of a mutant form of the protein Huntington. Everyone has the Huntington gene on chromosome number 4, and on that gene we have a trinucleotide CAG. This trinucleotide is repeated normally in all people. As you can see on the picture in the right, the CAG is repeated because the CAG is next to each other in the sequence. When people have fewer than 27 repetitions of the CAG, they are considered normal. However, when there are more than 40 repetitions of the CAG, this causes Huntington's disease. In the peripheral body, this abnormal protein does not kill the cells, but when the abnormal protein is in the brain, it kills the cells. Specifically, the basal ganglia is affected in this disease. Huntington's disease is diagnosed through a family history and a DNA test that shows the abnormal CAG repetition. Muscle movements are carried out through a communication loop called the frontal subcortical circuit. This is a loop between the motor cortex, basal ganglia, and thalamus. When cell death occurs in the basal ganglia, it causes a disruption in the frontal subcortical circuit. This damage leads to many motor impairments, including chorea, which talked about earlier is the uncontrolled movements, dysarthria, which is the loss of muscle group coordination in the mouth, dystonia, loss of muscle group coordination in other areas, bradykinesia, which is slow movement, rigid movements, myoclonitis, which is the spasmodic jerky coordination of muscles, tics, which are habitual spasmodic contractions of muscles, and tremors, which are quivering movements. Neurotransmitters are also affected in this disease. The most affected neurotransmitters are listed here. As I mentioned before, there is no known cure or treatment to change the course of this disease. However, pharmacotherapy is used to treat the symptoms. Tetrabenazine, seen here on the right, is used to treat chorea and psychosis. It is a dopamine-depleting agent that may be one of the more effective agents for reducing chorea, but it unfortunately has serious side effects. There are other drugs that are currently being developed with less negative side effects, but much research still needs to be done. These medications will help improve quality of life, but these people will still have speech, language, cognitive, and swallowing impairments that we need to work with. I will now discuss the clinical implications of this disease pertaining to our field. Starting with speech, hyperkinetic dysarthria is a prominent change in the communication abilities for people with this disease. This dysarthria is due to damage to the extrapyramidal system. Characteristics of hyperkinetic dysarthria include strained, strangled, and breathy vocal quality, poor respiratory control during speech production, inability to initiate and maintain speech production, prosodic disturbances through unpredicted pitch and loudness variations. Stress and intonation voice therapy and relaxation techniques have been found to be beneficial in the early stages of this disease. People with this disease also develop a fast rate of speech because they may rush speech in order to avoid the disruptions caused by involuntary movements. Self-monitoring can be a helpful tool to decrease the rate of speech. Individuals may also benefit from breathing exercises coordinated with speech to maintain a rate that is consistent with physiological capacity. Intelligibility is another speech concern for these people. Between their dysarthria and fast rate of speech, it can be difficult to understand these people, especially in the later stages. The next natural communication strategy that many families want to try is writing. However, they quickly learn that writing is also difficult due to the involuntary movements. Other forms of AAC devices should then be introduced to supplement natural speech. This disease affects language in many ways. First, they typically have word-finding difficulties, and their language becomes simpler throughout the later stages through a reduction of the number of words they use and the reduction of the complex syntactical structures. People with this disease have difficulty engaging in conversation due to their overall decrease in receptive skills and topic maintenance difficulties. Combined with latent responses, it is very difficult for these people to communicate with others. Due to the progressive nature, we need to help the environment be better suited for the person. It is important to train conversation partners to use simpler language so that the person can better understand them. We need to give the person time and encouragement to continue participating in conversations. The person's quality of life needs to be maintained as much as possible. Cognition is a large area of impairment for these people and can be very stressful for caregivers in the later stages. Overall loss of cognitive speed is seen in people with this disease. Specifically, they have an impaired ability to organize information, attend to a task, or have mental flexibility. They also have deficits in the ability to synthesize information, problem solve, and plan. These people also have difficulty initiating behavior. Caregivers often say that their loved one doesn't do anything. This is because they have difficulty initiating that behavior, but once they start, they tend to be okay. Perturbation is also common. These people tend to become fixated on thoughts or behaviors. Huntington's patients also tend to lose the ability to recognize emotions on someone's face. They can remember and identify emotions, but their lack of recognition is what leads to difficulty in social relationships. Their perception of time and space is also altered. They also lack a perception of their own disease, which is called anosognosia. Next, these people have difficulty controlling their impulses. Suicide becomes an issue in this population due to their impulsivity and depression. The comorbid mental illness prevalence rate ranges from 33 to 69% in patients with Huntington's disease, with the lifetime prevalence of depression estimated to be around 40%. It appears to be a direct neurological consequence of the brain conditions, rather than the psychological reaction to this serious illness, which is the opposite of what I think most people would think. In the later stages of this disease, these people become more psychiatric patients due to their delusions and hallucinations. Antipsychotic drugs can be used to suppress these symptoms. And finally, episodic and implicit memory are also impaired. Episodic memory is the information about personal experiences that have temporal and spatial context, whereas implicit memory is information regarding well-practiced behavioral routines like riding a bike, driving a car. But as the disease progresses, they eventually lose the ability to chew and swallow. And this is what brings me to the next section of the presentation about swallowing. The motor impairments seen in these patients not only causes them difficulty to walk or write, but it also causes them difficulty in swallowing. A systematic review of several studies found that the main problems in the preparatory oral phase are the postural instability, rapid impulsive consumption of food, and poor lingual control. In the oral phase, the main problems are an uncoordinated swallow, a repetitive swallow, and a residue after the swallow. In the pharyngeal phase, the main problems are coughing, choking, and aspiration. Here is a chart with more detailed information regarding all the dysphagia symptoms found in the systematic review. As you can tell, every person with Huntington's disease does not have the same clinical presentation of dysphagia. Prognosis is usually discussed during the topic of swallowing. People typically die 10 to 30 years after their diagnosis of Huntington's disease, and it is usually due to infections, which could be from aspiration pneumonia, or due to injuries related to falls, which could be due to their motor impairments. Now I want to talk about the acute care model because a Huntington's disease patient could end up in the hospital due to aspiration pneumonia or a fall. So it is important to remember that we will use this model when treating them. The patient and the family are, of course, the most important aspect of the acute care model. And another aspect of this model is the clinical facts and service delivery. This is where we would assess their speech, language, cognition, and swallowing, because all of these are affected in people with Huntington's disease. Psychosocial dimension is really important with patients with Huntington's disease. First, about the patient, because many of them have depression, like I talked about earlier. And even those without that diagnosis are still struggling to handle this terrible disease. The family and caregivers are also dealing with the stress of trying to take care of their loved one. The patient and the family have to bear such an emotional pain while dealing with this disease. The ethics, quality, safety, and cost-effectiveness component is important for this patient because swallowing usually brings up ethical issues and cognitive impairments usually brings up safety issues. So it's important to keep those in mind when creating a treatment plan for these patients. And again, it is important to use this entire model while in the acute care setting. And lastly, I would like to briefly talk about how to treat these patients. As I mentioned before, there is no known treatment to actually stop the brain from deteriorating. But speech-language pathologists can develop treatment plans to maximize their strengths, maintain their current functional skills, and use compensatory strategies for their weaknesses. Some examples of these include modifying their diet level, teaching swallowing techniques, using an AAC device, training communication partners, and finding ways for them to still participate in activities they like. The field of speech-language pathology has a huge part of quality of life because communication and eating are the epicenter of life and family. So it is our job to make this disease experience as painless as possible for people with Huntington's disease. In conclusion, Huntington's disease is a progressive neurological disease that deteriorates the basal ganglia. The hallmark motor symptom is chorea, and the clinical implications include speech, language, cognition, and swallowing impairments. As a speech-language pathologist, we will be working with all these areas to ensure that the person lives a better quality of life. And remember, we're always treating the whole person. Thank you.